Okay, thank you very much for invitation. Hello everyone. It's a tremendous pleasure for me to speak here to share our study. My name is Li Jun, a clinical doctor from the Department of Neurology, which belongs to the first affiliated hospital of Anhui Traditional Medical University in Hefei, China. Today, my topic is musculoskeletal pain in Parkinson's disease and Rtms intervention. First, as we know, Parkinson's disease is a neurodegenerative disease with diverse motor and non-motor symptoms. In recent years, the non-motor symptoms have attracted increasing attention. Among these non-motor symptoms, pain is the most frequently reported non-motor symptoms, with 60 to 85% of patients reporting it. Pain can occur at any stage of PD and can even be present before diagnosis. Pain is an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. This is from the latest definition from the International Association for the Study of Pain, IASP, in 2020. And according to the literature and our experience, we think pain greatly reduces the quality of patient's life, but it is often not recognized or treated as the motor symptoms. Researchers have not developed a consensus classification system for pain in PD. In 2008, pain systems were classified into three types by Professor Ligre Page: PD pain, non-PD pain, and mixed. And in 2010, the fourth classification system includes 5 types: musculoskeletal pain, radicular pain, dystonia-related pain, akathisia-related pain, and central Parkinsonia pain. And the latest classification system in 2015 divided PD pain into 7 types. And of these subtypes, musculoskeletal pain (MSP) is the most common one, ranges from 40% to 90%. It is defined as pain in muscles or joints, and which may be related to poor posture, and the MSP can present as aches, cramping, or muscle stiffness, and it's often relieved by a moment and all improved with levodopa. Clinical practice shows that the use of painkillers, opioids, antidepressants, and anticonvulsives is often not sufficient, and it does not readily respond to the medical and surgical treatments. So far, there's no standardized treatment plan for MSP yet, though we think further studies have to develop specific therapies. As we know, repetitive transcranial magnetic stimulation, Rtms, a non-invasive neuromodulation technique, involves delivering repetitive magnetic pulses to the specific brain area over a short period of time through the stimulation coil placed over the scalp. The repetitive magnetic pulses alter the excitability of the stimulation site and also influence brain regions autonomically connected to it. Because Rtms alters neural activity and yields behavioral impairments and can persist after stimulation, This technique has generated much more interest as a potential therapy for various neurologic and psychiatric disorders. Previous studies showed level A definitely effective evidence exists to support the benefits of high frequency Rtms applied over the primary motor cortex as a treatment for pain syndromes, including neuropathic and non-neuropathic pain syndromes. And the most commonly used Rtms frequencies are 10 Hz and 20 Hz. But previous studies of Rtms have mostly focused on PD and pain syndromes, respectively. No study has specifically tested the effects of Rtms on MSP severity in PD patients. So we want to test if M1 target high frequency can relieve MSP in PD patients. And before the trial, there are 4 studies registered in clinicaltrial.gov, 2 from Brazil, 1 from France, and the last one is our study. And this is our objective. The basic idea is very simple. We just want to test the hypothesis that if M1 targeted high frequency Rtms can relieve MSP in PD patients. So our inclusion criteria is A, subjects aged 18 to 80 years old. B, stable anti-Parkinsonian therapy for at least 2 weeks. And C, Hoehn and Yahr stage from 1 to 4. And all the subjects had to stay on their medication regimes throughout the trial. And the exclusion criteria included A, contraindications to Rtms, B, histories of deep brain stimulation surgery, C, MSE less than 24, D, marked wrist tremor, E, histories of receiving any kind of Rtms, and F, conditions other than PD that can cause pain such as cancer, diabetes, apparent osteoarthritis, or rheumatoid arthritis depended on laboratory or imaging finds. So 52 PD patients with MSP were recruited through the Movement Disorders Clinic of Xuanwu Hospital of Capital University in Beijing, China, between 2019 to 2020. Idiopathic PD was diagnosed according to the 2015 Movement Disorder Society clinical diagnostic criteria. This was a randomized, double-blind, sham-controlled trial with a parallel design in which the participants were divided into groups that either received 20 Hz Rtms or sham stimulation of the M1. The participants were randomly assigned to groups in a 1-to-1 ratio. The Rtms and sham protocols were performed across 5 consecutive daily sessions at an approximately consistent time of the day. The participants underwent clinical assessments at baseline and at 3 follow-up time points. The first follow-up occurred immediately after the 5th Rtms or sham stimulation sessions. The second and the third follow-up occurred 2 weeks later and 4 weeks later, respectively. All assessments occurred at approximately the same time of the day. And the assessment scale included Part 3 and Part 4 of the MDS Unified PD Rating Scale, Hamilton Depression Scale, the Hamilton Anxiety Scale, the scales for outcomes in PD autonomic symptoms, the PD Sleep Scale 2, and the Parkinson's Disease Questionnaire. The Rtms and sham stimulation groups both had 26 members initially, but each group lost 2 members to follow up. The participants' demographic and clinical characteristics are shown in Table 1. From this table, the Rtms and sham stimulation groups were similar in terms of baseline characteristics. Finally, after the trial, we analyzed the data and got the results. We can see from the picture. The red lines are the Rtms groups, and the blue lines are the sham groups. From the part A of the picture, the Rtms group exhibited significant improvement in pain scores from the baseline, with pain scores reductions at each follow-up time point, while no pain score changes were observed in the sham stimulation group from baseline. From the part B of picture, MDS UPDRS 3 scores revealed significant improvements. From the part C of the picture, Hamilton depression scores revealed significant improvements. From the part D of the picture, Hamilton anxiety scores revealed significant improvements. And from the part E of the picture, PDQ-39 scores revealed significant improvements. But here, although the group differences in Hamilton depression, Hamilton anxiety, and UPDRS-3 scores were statistically significant, but the changes scores were relatively small in the whole scale and maybe not clinically significant. During the study, we found the Rtms and sham groups have similar adverse events during the trial. Besides 2 patients withdrew due to the headaches and dizziness in each group, no serious adverse events occurred. The most common adverse events were headaches, dizziness, tinnitus, and transient aggravation of gait disturbances. And this is our paper published in Parkinson's and Related Disorder in 2020. But our study also has several limitations that we should be noted. First, in the present study, we applied a traditional but commonly used protocol by orienting the core 90 degrees as the sham strategy. Second, we did not rule out depression and anxiety patients in our study. Emotional factors affect the interpretation of the primary outcome. However, as over 90% of patients with PD have comorbid depression, so excluding emotional factors completely might lead to the selection simple bias. At last, because we were investigating the short-term analgesic effects of Rtms, the trial assessments were conducted for only 1 month. Our finding may therefore not reflect the long-term effect of Rtms. So, in conclusion, our findings suggest that M1 target high-frequency Rtms elevates MSP, reduces motor symptoms severities, and improves quality of life for patients with PD and MSP. And it can serve as an adjunctive therapy for alleviating MSP in PD patients. At last, let me present my boss and lovely fellows. My boss is Professor Pu Chen, a great person in Capital Medical University. Much appreciate for their help. And now, it is just after the China Spring Festival, so Happy New Year of the Tiger. Best wishes to everyone for the year to come. Thank you very much. Thank you.